Good afternoon. Thank you for joining us for the webinar Antibiotic Allergies in Children. This webinar forms part of the Rural Health West 2020 virtual conference. Before I hand you over to our presenter, I'd like to run through some brief housekeeping. If your audio is not coming through too clearly, you may prefer to switch to audio via your phone. These numbers will be listed on your dashboard. Remember to enter the PIN number too. Everybody has been placed on mute to minimise background noise, but we would still love to hear from you. Please enter any questions into the question box, which you can see on your dashboard. These will be answered at the end of the presentation. This session will be recorded and uploaded to the Rural Health West website under the virtual conference banner. I'll now hand you over to your presenter, Clinical Professor Michaela Lucas.
So today I'm just going to give you a brief update on antibiotic allergy in children. And first of all, I'm going to talk a little bit about what the term allergy means. So this is a talk about adverse drug reactions, and the WHO definition of an adverse drug reaction is a response to a drug which is toxic or noxious and unintended and which occurs at normal doses. So this is not referring to it's not a reaction that occurs because you've taken an overdose of the drug. This is really due to an effect that's unintended. Once we believe that there is an immunological cause for this unintended response, we talk about an allergy, and that's the definition of a drug allergy per se. So a damaging reaction caused by an immunological response to a drug, and in general, these responses are unpredictable and occur at random. Looking at the current adverse drug reaction classification, the allergies fall into the type B adverse drug reactions. So just to remind you again, when you have an adverse drug reaction, you might have a type A reaction. This is common, predictable, and dose dependent. For example, a bleeding ulcer after taking aspirin. If you have a type B reaction, they are uncommon, unpredictable, less dose dependent, they're host factor dependent, and fall into three groups. So there's these idiosyncratic groups where we don't know but suspect there might be immunological mediated, but it hasn't been shown yet. We generally put them into this group. There is pseudoallergies where drugs directly might lead to histamine release. And in this group, for example, there is asthma induced by aspirin, vancomycin, Redmond syndrome, or flushing and heat and rashes after radiocontrast. The allergic reaction are those that are due to an underlying allergy with an immunological cause. And the two most common drug reactions that we see are type 1, immediate IgE-mediated reactions, or type 4, delayed T-cell mediated reactions. And the type 1 mediated reactions might be very well known to you because they're the same type of reactions that occur, for example, in peanut allergy. So they're these IgE immediate release often histamine-related reactions. So let's talk about immediate IgE-mediated drug reactions. So an IgE-mediated immediate hypersensitivity, which is another term for allergy, is caused by the presence of penicillin-specific IgE bound to basophil or mast cells. So basophils are your cells within the peripheral blood. Mast cells are tissue-resident cells. The reaction occurs typically within minutes of exposure to a parental penicillin, and if you orally ingest the penicillin and it needs to be processed, this can be delayed up to 1 to 2 hours after oral drug ingestion. In some drugs, this can be even later. For example, protein pump inhibitors, often the reaction occurs up to 4 to 6 hours after. Manifestations are those classical manifestations that result from mast cell degranulation with the release of mediators such as histamine, leukotrienes, and other inflammatory chemokines and cytokines, just like what you would know in your food allergies, for example, a peanut allergy. If the reaction is more delayed, it is less likely that this reaction is IgE-mediated and more likely that it might be T-cell mediated, so therefore non-immediate reaction. For penicillin, severe reactions such as anaphylaxis occur at an estimated frequency of 1 to 4 cases per 10,000 courses, and 10% of these initial anaphylaxis reactions may be fatal. So what are the clinical presentations of an immediate IgE-mediated reaction? You can have, just like with your food allergies, mild, moderate, or severe symptoms. So mild to moderate symptoms would be urticaria, angioedema, not associated with shortness of breath, commonly around the face, hands, feet, or eyes, rhinoconjunctivitis, and gastrointestinal symptoms. Of note, though, these gastrointestinal symptoms have to be severe, so it's not enough to say, I've taken the antibiotic and I had a little bit of abdominal pain. You really need to have significant vomiting or diarrhea and abdominal pain to group this into a mild to moderate symptom after an allergic reaction. Mild gastrointestinal symptoms are often a side effect of the drug and not due to an allergy. The severe anaphylaxis symptoms are, of course, those that involve the airway or your circulatory system, and they are associated with difficulty in noisy breathing, swelling of the tongue, swelling and tightness in the throat, wheeze or persistent cough such as bronchospasm, persistent dizziness or collapse, elevation of serum mast cell tryptase within 1 to 4 hours of reaction, and this elevation of the mast cell tryptase within that time confirms an IgE-mediated reaction, as it sort of basically measures histamine release by the mast cells during that time. So, and tryptase is released at the same time. So that's always a very good test to keep in mind if you are observing acutely a drug reaction and you want to know if this was an IgE-mediated allergy or not. It was really helpful 2 hours after the reaction or within that time frame of 4 hours to take a mast cell tryptase. Delayed non-immediate adverse reactions may occur at any time after 1 hour from the initial drug administration, and they have a very heterogeneous clinical picture and pathogenesis. They can result from the activation of penicillin-specific T cells with the subsequent activation of macrophages, neutrophils, eosinophils, so the classical innate cells that are associated with these reactions. They can be serum sickness-like reactions with antibody-antigen immune complexes and unknown mechanisms. So these non-immediate reactions are very large group, and they really range from these very simple benign rashes, which are often macular or macular-papular rashes, all the way to a rash that might be associated with a severe cutaneous adverse drug reaction. Clinical presentations of the delayed reactions can be most commonly an eczematous rash, particularly in children. We see this very commonly. Furthermore, it can be moderate with delayed urticaria, and that's a very confusing thing because urticaria is often thought to be associated with IgE-mediated reactions, but if urticaria occurs delayed, it can be also associated with a non-immediate adverse drug reaction, which is not IgE-mediated. There are macular-papular eruptions. There are fixed drug eruptions, which are drug eruptions that occur at any spot. This is particularly CD8 T cell mediated, and you can also have a moderate reaction called AJAK, where you get a pustulosis, so multiple pustules throughout the body. And then there is one moderate reaction which borders severe, which pretty much presents like a SJS, like a Stevens-Johnson syndrome with really significant erosions. But these erosions are symmetrical, and they will only occur in the intragenous and flexural sites. So often in the axilla, the elbows, the groin, and this is called S-drive. Clinical presentation of delayed non-immediate adverse reactions that are severe are all of those that have organ involvement or vessel involvement. So it could be vasculitis, it could be toxic epidermal necrolysis, where your T cells kill your keratinocytes. That's a similar pathogenesis for Stevens-Johnson. If you have got limited skin extent, up to 10 to 20%, it's Stevens-Johnson. If it's over 30%, it's toxic epidermal necrolysis, and in between you call it SJS10. So you may have seen that written in letters. There is also a systemic drug reaction associated with eosinophilia called DRESS syndrome. And it's not only fever, the patient being unwell. This often goes with abnormalities in the liver or the kidney. In fact, there is sort of like a kidney-related DRESS and a liver-related DRESS. Internal organs can be affected either alone or with cutaneous symptoms. So you could have a leukocytoclastic vasculitis with hepatitis and so on, or you might just have hepatitis, renal failure, pneumonitis, or you can have abnormalities such as anemia, neutropenia, and thrombocytopenia. So the majority of non-immediate reactions are really mild to moderate. So you can have macular, papular, or morbilliform rashes. The typical history in a child will be that these are occurring several days into the commencement of the treatment, most commonly the second or third day of treatment. And they are a lot more common than immediate reactions. In fact, probably about 80% of children that present with a beta-lactam, a history of a beta-lactam allergy, will have such a rash. Delayed reactions often occur in the context of a concurrent viral illness, and the classical example from the past has been Epstein-Barr virus infections, particularly in combination with ampicillin treatment. Now, we don't use ampicillin that commonly anymore in our practice. We now use, in the majority of cases, amoxicillin, and it is lesser seen with amoxicillin. If somebody has an underlying HIV infection, which of course in children in this country is rare, they also tend to develop more viral-associated rashes. Of course, if you then re-challenge the child to the particular drug in the context when they're well, for example, they've cleared the EBV infection, that rash is not reproducible. Overall, of course, viral lexanthematous are common in children, and that probably leads to the fact that the majority of children that develop a rash while being on an antibiotic are not allergic. Delayed mild eczematous rashes, especially with aminopenicillins, are not very strongly predictive of future reactions. Probably only about, and I'll talk about it in my second part of the talk, 10% of children that present with a benign rash will truly have a reaction to the drug, whether a non-immediate or immediate reaction. And the only way really to find out if the majority of children that present with rashes while they're on antibiotics have truly an allergy against that antibiotic is a direct challenge with the culprit antibiotic. That, of course, always has to be done under medical supervision. So when you look at our data from the Post Children's Hospital or at the literature, and I've just quoted here the very first paper from Kubi from 2011, it's roughly 7 to 10% of children with a previous history of a rash that then will have a positive challenge upon oral provocation. And the majority of these children will develop a rash again when exposed to the antibiotics. And you do need to, even in the challenge, give an extended course of that antibiotic. So probably only about 2% of children will directly react to the antibiotic with a single challenge. If you then continue the antibiotics for up to 5 days, you pick up the rest of the 8% that makes the 10% in our data. Occasionally, reactions can occur after a course of antibiotics, but if you review the literature carefully, it's never been described that a rash occurs after 2 days. So once a child has stopped the course of the antibiotics, for a classical non-immediate reaction, rashes that occur after the 48-hour period after cessation of the course are generally not associated with the antibiotic. They may have another cause. Rashes may persist, of course, for weeks after cessation, although the majority will resolve within 24 to 48 hours. They can be itchy, and they often respond to antihistamines, even if they are T-cell mediated. If a child comes in with a history and has a rash that persists for 2 weeks, That again is a predictive factor that this rash may occur in the future with the antibiotic. Other examples of very severe delayed reactions that are occurring after the course of antibiotics is serum sickness-like reactions, which classically occur 1 to 2 weeks after the course of antibiotics, characterized with a vasculitic rash, arthralgia, and arthritis, a very high CRP, often low complement levels. So bloods in that context are really, really helpful. Flu-like symptoms, sometimes fever and proteinuria. They often can also present with a severe urticarial rash, which can be an urticarial vasculitis, hence the complement levels can be low. Stress syndrome, this systemic reaction with eosinophilia and kidney and liver involvement, classically occurs about 8 weeks, 6 to 8 weeks after the exposure to the medication. So it's very delayed. And it's very important to recognize this as one of the severe cutaneous adverse drug reactions. The most severe form is probably Stevens-Johnson syndrome and toxic epidermal necrolysis, which requires very often treatment in the burns unit. This occurs classically within 7 days, and often with the first course and exposure of this antibiotic, because if you have the genetic susceptibility to make a reaction against these drugs, they pretty much, once you start the drug, you start to make a T-cell response that then peaks at about 7 to 14 days, and that's when you clinically will develop the symptoms. This often starts with the mouth ulcerations, but also a severe conjunctivitis. And if somebody feels unwell and they've taken a medication and now they're not getting better, you're starting them on antibiotics as well, really find out if they have got involvement. So if they have a very significant conjunctival injection or have mucosal ulcerations, they really need to be monitored extremely closely, because the skin rash that goes with these reactions initially looks fairly benign. It can start off just as 20 papules and rapidly progress to a severe burns-like illness with sloughing of the epidermis, and it is fatal in a lot of cases. They need to be referred to a specialist center early, because treatment with high-dose corticosteroids, as well as cephalosporin, as well as now newly TNF-alpha antagonists, alter the disease course. Then there is AJEP. I've already talked about this. It's generalized eczematous pustulosis. That's uncommon. It's probably a little bit more benign, and it's also again associated with general malaise and fever. The main point I would really like to make about these severe delayed reactions, that they're all associated with fever and flu-like symptoms. So if somebody just has a skin rash and doesn't really feel unwell, doesn't have these flu-like symptoms, it's less likely to be one of these severe delayed reactions. But if somebody comes in and develops flu-like symptoms, is generally feeling unwell, and has a mild skin rash, that's often a sign that a severe delayed reaction may follow. In the acute setting, it's always important to take a photo of the rash. It's also important to do a biopsy if you can do so. And you want to accompany this with laboratory testing, blood picture, biochemistry, complement levels, as well as your CRP. Often iron studies looking at a high ferritin can be also useful. Patients with severe drug hypersensitivity have to wear a medical bracelet. They should have this documented in their health record, in my health record, and they should also be very aware of their allergy status and avoid this drug lifelong. Sometimes, of course, it's difficult to differentiate your rash that's associated with viral infection from an antibiotic rash. And I mean, honestly, in the majority of cases, you may not be able to do so. So we did see these rashes in EBV and ampicillin more commonly in the past, but with amoxicillin, luckily, it's less common. We don't really know what the interaction is that leads to these rashes, and it is often unclear, as I said, if the rash is virus dependent or a drug reaction. So the best is to actually do your viral rash serology to look for an infectious cause. If that comes positive, then it's less likely to be the antibiotic and you can remove that label. Otherwise, you will need to re-challenge that child again when it's well to the antibiotic. And that can be done together with your allergist advice. But obviously, there's also new guidelines hopefully coming out that will allow kids with a benign rash to be challenged in the outpatient setting. So I'm just stopping here for a second and just checking with Kate that she can still hear me fine.
Hi, Michaela. Yes, I can still hear you fine, and there are no questions as yet.
Okay, perfect. Thank you very much.
No worries.
So after this first part of the talk, I'm now going to talk to you a little bit about the rate of penicillin or antibiotic allergies in children, really focusing on data from Western Australia, because the majority of data that we have on this topic are whether coming from Europe or from America. So there aren't a lot of Australian data, but I'll share some of the data that we've got from our studies here. So as you will all know, the majority, and this is why I'm mainly talking about penicillins or beta-lactam antibiotics in my talk today, patients that present to a GP practice or to a practice will have an allergy to penicillin. And this presence of a penicillin allergy, what we often call a penicillin allergy label, because it's unconfirmed, it's self-reported or parent-reported, it probably means that the patient has had an adverse event associated with the penicillin in the past. And in the majority of cases, this will have been a rash in the context of having an infection, which may have been viral or bacterial, and presented with a rash while being on antibiotics. So in the classical history, this patient will have then gone to their GP, just as I explained before. They would have not at that stage been able to distinguish if this was infection-related or antibiotic-related. You stop the antibiotic, and the patient remains being discharged with a potential penicillin allergy. So far, we've done very little to actually address this problem, because it's very difficult often to refer the patient to a specialist, and also in the context of our community outpatient services to address these penicillin allergy, they are currently sparse, but hopefully that will change. What we realized is that in our hospitals within Australia, and this is adult data, that about 18% of people coming to our hospitals these days will have such a penicillin or beta-lactam allergy. What is also very interesting that the prevalence of reporting an antibiotic allergy or an antibiotic allergy label increases with age, and there's a predominance of elderly females. Now, genetic studies have shown that there is possibly a slight gender difference between allergies, particularly medication allergies, and it might be a little bit more common in females. But it might also be a reporting bias that females are more likely to report an antibiotic allergy than males. We don't know the answer for that yet. We also know that if you assess these patients presenting to their doctor with a presumed penicillin allergy or a penicillin allergy label, and you systematically line them up and you test them with skin tests and then with a challenge, that 90% of these patients will not have a penicillin allergy. It's a mislabel. So what that means is that we are now in a situation where up to a fifth of patients presenting to our healthcare services will report a penicillin allergy. And only 10% of those patients will actually truly be allergic. And it's become a bit of a messy field, because now that label means people don't believe it because they think it's unlikely to be a true allergy. So there is a safety risk for those that have a true allergy. And on the other hand, you have to sort of like avoid penicillins in these patients unnecessarily in those that don't have a label, that don't have a true allergy. So therefore, the overall recommendation from the infectious disease doctors, as well as from the immunologists, has to be now that further evaluation should be considered for any patient that presents with a penicillin allergy label. Although we realize that in the context of the current referrals and getting access to these services is limited. Hence, I'm starting to talk about outpatient challenges that could be done possibly in the GP, and we're working towards that. So the rate of patients with self-reported allergy in the primary care setting, so who comes to their GP and reports it, is not very well known. Although there's very good practice software to actually report these, the rough number is probably sitting at about 11% in the general, primary healthcare. The self-reported antibiotic allergy in Australian children is not very well studied. It is 5.4% at PCH, and that's a large study that we did now in over 2,000 children. Older children, again, are more likely to have an antibiotic allergy than younger children. So there's definitely this age factor. And this is just a chart from all the data that we've got. So this is taking all the WA patients together. This is probably looking by now at about 3,500 patients. And it shows you very clearly how the rate in the 0 to 5-year-olds probably sitting at about 2.5–3%, and how it then goes up with age. And the blue bars here are the females and the green bars are the males. And you can see in children, it's a little bit more even up to the age of 20, but then you can see how this penicillin allergy reporting or self-reporting as penicillin allergy is dominated by females. And in the plus 80-year-olds, and that's a big problem in our geriatric units, 25% of patients will report a penicillin allergy. Overall, the most common antibiotic that is reported is a penicillin that's not otherwise specified in these, followed by cefalexin and amoxicillin, and then tazocin and cefazolin. Then it's followed by Septrin, because a lot of patients that have an allergy to beta-lactams or penicillin are given Septrin, and Septrin itself is associated with a high rate of a rash. So once they have one label, they accumulate that second label very quickly. And in adults, about 90% have a single allergy. In kids, that's almost 100%. So this is the adult data. In children, it's exactly the same. So mostly penicillin, not specified, followed by amoxicillin, then cefalexin. And it's really probably reflecting the majority of those reflecting use of antibiotics within a country. And then it's followed by cephalosporin or trimethoprim, and the majority of children will have only one label, which makes them very easy to delabel rather than adults. When I see some elderly females, they come in and they have 4 or 5 antibiotics that they're reacted to. And most of the time, because of a penicillin label, they accumulated these other labels over time, but then will not have any allergy. So I'm now talking about what are the implications of presenting to our healthcare system and self-reporting a penicillin or a beta-lactam allergy. And there's lots of international studies that have looked at this, and the most notably is probably one from last year by Kimberly Blumenthal that was published in the BMJ. So in adults, there's more data than in children, so I'm having another slide on children as well. But it's likely that these are also true for children. That's why I kept them in here. So although penicillin allergy labeling or avoiding penicillins in somebody that self-reports a penicillin allergy is used to protect patients, because you don't want to give them a reaction, it results in restricted access to antibiotics and the avoidance of penicillins, which are safe, cheap, and effective, and very importantly, are very narrow spectrum. So in fact, are a lot better for your microbiome than antibiotics that are the alternatives, which are often broad-spectrum antibiotics, and not only broadly are effective against pathogenic bacteria, but also broadly eradicate a lot of your natural microbiome flora. And hence, making space for bacteria that we otherwise would not see in healthy hosts. This is the reason why we see these multi-resistant infections. So restricted access to antibiotics in the context of a penicillin allergy leads to inappropriate avoidance of all beta-lactams, because often people can't work out, oh, they have a penicillin allergy, but they're not sure, so maybe they can't have cephalosporins either, so let's just avoid all of them. It is clearly associated with poorer clinical outcomes. People that come to hospital with a penicillin allergy stay in hospital longer, worldwide and in Australia, have higher ICU admissions, have higher rates of readmission, have higher mortality rates, and have an increased risk of these multi-resistant infections with MRSA and C. difficile infection due to the overuse of antibiotics associated with those, which is, in one context, quinolones, as well as vancomycin. In children, it has exactly the same impact. So patients with an antibiotic allergy label presenting to PCH will get fewer penicillins because they have a penicillin allergy, but they'll get more macrolides, more quinolones, more lincosamines, and more metronidazoles than patients without an antibiotic allergy label. And this is exactly the pattern of antibiotic use you see in this large BMJ study in adults that leads to this increased risk of C. diff and MRSA infection. Importantly as well, what we see that in women that present with a penicillin allergy, they are given more macrolides in pregnancy, and that is linked to increased birth defects, and that's a paper that also was just recently published in the BMJ. So reporting with something as simple of a penicillin allergy that you might have got because at one point it started off with a rash you had in childhood, which was concurrent with a viral or bacterial infection, now leads to a negative impact on your whole healthcare throughout your life. Hence, it's so important to find ways of addressing these allergies early. And childhood is a very safe time to address these antibiotic allergies. So the burden of self-reported antibiotic allergy in Australia is very high. Just we have a high rate for any kind of allergy. It's probably about 10 to 15% in other countries. It's sitting here close to 20%. Overlabeling can set up a negative cycle of restricted access to antibiotics, poorer clinical outcomes, increased AMR, and hospitalization. And if we would have a way where we systemically delabel these patients and assess them, hopefully close to their actual reaction, this might mitigate many of the clinical and economic burdens that are associated with such unaddressed penicillin allergy labeling. So, at this current stage, when should you refer a patient to a specialist? The time when you should refer a patient to a specialist should be at this current stage given to those that are in need of antibiotics. So these are children with chronic diseases, for example, cystic fibrosis, that are commonly requiring frequent antibiotics. They are for those patients that require repeated courses of antibiotics each year. Very young children that are already in need of antibiotics. All patients who had a severe allergic reaction, so we can make sure that the proper documentation follows to ensure they do not get these antibiotics again. And armed forces recruits, because it often impacts on their recruitment to military. If you have got patients that have a known immunodeficiency or have multiple drug allergy labels affecting 2 or more classes of antibiotics, they also should be referred, and they will be given priority to be seen. On the ASCIA website, there is a pre-clinic questionnaire that you can fill out and use as well to facilitate referral. So the role of a general practitioner or a practitioner, nurse or pediatrician in this context will be to provide us with the relevant clinical history, and it's particularly the timing between taking the drug and the reaction and the type of reaction that is important. If somebody experienced a very severe reaction and you're convinced that this was a true IgE-mediated or non-immediate reaction, tell them to wear medical identification jewelry. And this is only, of course, required for the severe reaction. Also make sure that they're encouraged to put down that information in the allergy section of My Health record. You can test for serum-specific IgE, so a test formerly known as RAS, if the reaction really occurred within the 6 to 12 months prior, ideally within 6 months. After that, it's very likely to be falsely negative. This test is really only good if used very early on. After that, the IgE will wane in the serum and the concentrations will be too low to be measurable. You need to educate the patient and carers in recognition of these reactions and tell them to strictly avoid the antibiotic at least until they had testing. It's very important to tell them that they will not get an adrenaline auto-injector. We do not give EpiPens for drug allergy. This is really for food allergy, but it is not for drug allergy. And he can provide them with some educational material, again, which can be obtained from the Askia webpage. What we really would like you to write in your letter is the drug and date prescribed, the dose, the route, the frequency of the drug, the reason for the prescription, because it sometimes gives us an idea of if the child might have had a viral infection or not, the reaction, particularly the type, the duration, how long did it take for these symptoms to resolve, and the management. Did you need to give adrenaline? Did you need to give steroids? What did you do? And other medications given around the time of reaction. In children, that's mainly ibuprofen because certain NSAIDs can make reactions worse. So once you refer a patient to our service, what does it involve? So the role of allergy testing, which uses skin testing, is mainly tailored towards IgE-mediated reactions. Children with a history of an immediate reaction should have skin testing prior to a challenge. Negative results in the skin testing depends a little bit when you perform the skin testing, and it's best within the first 6 months after the reaction. Intradermal testing should be done in a specialist center. It is associated with the risk of anaphylaxis, and the results are truly difficult to interpret in many cases, so it's good if you see a lot of these tests. And I've already commented on serum-specific IgE. So for non-immediate reactions in mild cutaneous delayed reactions without systemic involvement, so a benign rash, no systemic symptoms, no mucosal involvement, a direct drug allergy challenge for children is now recommended. And that's often done as a 2-dose challenge, so we give 1/10 of a dose followed by the rest of the dose. So you no longer need skin testing in children that present with a benign rash without systemic involvement to an antibiotic. Of course, you need to perform that challenge in a context where anaphylaxis can be safely managed. Patch testing or intradermal tests with delayed reading. So you do an intradermal test and you read it like a MAN2 test, pretty much 48 or 72 hours after. As a T-cell, to measure a T-cell mediated reaction, is useful for the diagnosis of certain types. And we use this quite commonly in the context of more severe non-immediate reactions. In patients that have DRESS or SJS/10, challenge is strictly contraindicated as it can be fatal, so you can never give the drug again. In vitro drug-induced T-cell activation or proliferation assays are used in some centers, but they're mainly research. In these severe cutaneous adverse drug reactions like DRESS and SJS/10, cross-reactivity is not well understood. So if they have a reaction to a penicillin, you better avoid all beta-lactam antibiotics. So don't start maybe trying cephalosporins and see if they're okay, because they do have cross-reactivities which are truly not well understood. Talking about these direct challenges, this is the risk of adverse reactions shown here. to these direct challenges in an outpatient setting from a recent publication. And what I wanted to highlight here, you can see an iron infusion reaction is about 1%. Any adverse reaction, diarrhea, rash, or candidiasis during the course of penicillin is over 1%. These are non-allergies. To have an objective reaction during a low-risk penicillin outpatient challenge is 1.3%. So this is giving a 2-dose drug challenge to somebody that had such a benign rash without systemic symptoms. So it's about 1% that might have a reaction. All of the objective reactions in this particular study, which looked at about 700 patients overall, was a mild rash. None of them developed anaphylaxis. To develop any reaction during a high or after a low-risk penicillin challenge is roughly 3%, and they're mainly gastrointestinal symptoms. So doing a penicillin challenge in the outpatient setting or at your GP practice would be very similar to giving bee venom desensitization as a maintenance or giving varicella zoster injection. So the side effects or the having a reaction is not very likely to these penicillin challenges, and also it is safe if you do it as a 2-dose challenge. The majority of those with a more severe allergy will react to the 1 in 10 dose with a lesser reaction, which is not anaphylaxis. So what is your treatment of these IgE-mediated reactions? For mild to moderate allergic reactions, of course, you give oral non-sedating antihistamines. We don't recommend sedating antihistamines at all anymore in ASCIA, for allergic reactions as part of the ASCIA guidelines. Of course, in a severe allergic reaction, you follow your action plan. You call for assistance. You lay the patient flat. You give intramuscular adrenaline if available. You repeat every 5 minutes as needed. And if multiple doses required, you may consider an adrenaline infusion. You give oxygen, and also importantly, if they have got cardiovascular compromise with a blood pressure drop, you give fluids and you call an ambulance. The treatment of non-immediate allergic reactions depends, of course, on the severity. Again, oral non-sedating antihistamines against the itch. Topical or short course of oral corticosteroids may be indicated for some of those rashes that are a little bit more persistent. But if they are severe, you suspect any of those associated particularly with systemic symptoms, you transfer to specialist care immediately. So my last 3 slides are just a little bit of additional information on the cross-reactivity between penicillins and cephalosporins, because there's often a lot of confusion. If you have an allergy against the penicillin, you may have that allergy against the beta-lactam ring itself, or more commonly against the side chain that is associated to that beta-lactam ring. So in aminopenicillins, you would have the beta-lactam ring and you would have an R1 side chain, which is your amino group. So the majority of reactions we see are directed against the R1 side chain. Very rarely it's directed against the beta-lactam ring. Only if you have an allergy against the beta-lactam ring, you will also need to avoid penicillins or cephalosporin. But as I said, that is extremely rare. The majority will be side chain, and these side chain reactions, depending then not if it's a penicillin or a cephalosporin, it's more dependent if your cephalosporin and penicillin share that side chain. So cross-reactivity can occur based on molecular similarity between the beta-lactam rings or the side chain. In patients with an IgE-mediated penicillin allergy, the rate of cross-reactivity with first and second generation is less than 2%. So if somebody has a penicillin allergy, the cross-reactivity or the chances having a cephalosporin allergy as well is less than 2%. It's even lower for third or fourth generation cephalosporin. Carbapenems such as imipenem may cross-react, but it's very rare and should be given under specialist guidance or with caution. Monobactams like Astreonam are absolutely safe to give in penicillin allergic subjects. Sometimes, if we can't determine if somebody has an allergy or not, and we have to give the antibiotic quickly, like Septrim in HIV patients or ciprofloxacin quinolone in a CF patient, or some people that really need penicillins urgently and they're too unwell to be challenged, you can do a desensitization, which is giving the penicillin or the drug of choice very slowly to the patient in multiple doses. So it's often a 7 to 10 step protocol where you start with a 10,000 dilute drug, building up to the full dose that the patient needs. This often needs to be done in an ICU or HDU setting, should be always done under specialist guidance, and it's based on the fact that you desensitize the mast cells or the T cells. So they are often, if they have a true allergy, symptomatic all the way to developing anaphylaxis, but you treat through this and you continue to give increasing doses. It's important that if somebody has been desensitized for a drug, this is only an induction of temporary tolerance. They will only be desensitized while the drug is still around because their mast cells or T cells are stunned. As soon as you stop and these cells recover, they will be as allergic as they will be before. So this really brings me to the last slide, and I'd just like to thank you all the people, and I'm happy to take any questions.
Wonderful. Thank you so much for joining us on the webinar, and we hope you have enjoyed this session. I would just like to say thank you to Clinical Professor Michaela Lucas for her time this afternoon and for being a part of the Rural Health West virtual conference. If you do have any questions, now is the time just to pop them in the questions box and we can ask Michaela those questions for you.